Hello, and welcome to the Chest Journal Podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Alice Gallo de Moraes.
Hi. Thank you for joining us for another amazing Chest Journal podcast. I am Alice Gallo. I'm an intensivist at Mayo Clinic in Rochester, Minnesota, and today I have the pleasure of talking to Dr. Elias Pratt about the association of RBC transfusion thresholds and outcomes in medical patients with acute respiratory failure supported with extracorporeal membrane oxygenation, a single-center retrospective cohort study. Hi, Dr. Pratt, and welcome to the podcast.
Hi, Alice. Thank you so much for having me here.
Thank you so much for being here with us. I'm excited to talk to you about your work. So I was hoping to hear from you about what inspired you to look into transfusion thresholds in patients with respiratory failure on ECMO. And if a patient inspired you, what was your inspiration and a little bit of background on your work?
Yeah, so I am a pulmonary and critical care physician at Duke University Medical Center in Durham, North Carolina. And my interest in ECMO and transfusion thresholds is more just a part of my broader research interest. So I am a clinical researcher, and I am interested in management of patients with acute respiratory failure, especially severe ARDS, and looking at how to improve outcomes. Mm-hmm. So at Duke, we are a large volume VV ECMO center. So, we as a medical center are, I think one of the top 4 or 5 volume of VV ECMO centers in the United mm-hmm. States. Mm-hmm. And really early on, we moved, our VV ECMO and ARDS patients into our medical ICU. So not in a surgical ICU, but in a medical ICU. And so we sort of have a really, I think, a longer clinical experience managing VV ECMO patients patients with ARDS supported with VV ECMO in our medical ICU. And we have just come to realize that there is not a lot of good quality evidence to guide the management of these patients. Yeah. And so we have a research program that we've been building over the past couple of years that is trying to leverage our clinical experience to generate at least preliminary data to help guide how we should manage these people. One issue that always comes up in the management of patients on VV ECMO is red blood cell transfusions. So, back in the day when ECMO was first being used as a form of support for acute respiratory failure, there was this, I think, common perception that you should transfuse to sort of a normal hemoglobin, right? So if you look back in the ELSO red books, the 4th and 5th edition, they recommended transfusion for hemoglobin of 12 to 14. Mm-hmm. And when we first started ECMO in our medical ICU, it was 2009, and so that was sort of the predominant thought. But over time, like many other larger volume ECMO centers, we changed our transfusion practices, and we did it in a way that was structured. So we have an internal protocol that we use for the management of patients on VV ECMO in the medical ICU, and as part of that protocol is a recommended transfusion threshold. And so we wanted to see that if there were any changes associated with the institution of these protocols within the medical ICU. And so it was just sort of curiosity of, we've changed our practice over time and seeing how that change in practice might have affected our patient.
Yeah, I love that. And so then with that, great segue. Okay. Share with our listeners how you designed your study, because I know there were some different thresholds that you and your team used, right?
Right. So I think when I try to explain this study to people, I say that we were trying to do the best study we could with imperfect data. So I think, the big caveat to all of this work is that it's retrospective. And so there is just inherent confounding that we can't get rid of. And so we wanted to try and approach this in a way that was as methodologically rigorous as we could, while still acknowledging that it's retrospective data. And so we have a database of every patient who has been supported with VV ECMO in our medical ICU since 2009. And this is sort of like a living, breathing database that we, not when I say we, I mean myself and really Craig Rackley, who's the medical director of our ECMO program here, has sort of built over the years. And so we have this database, and as part of this database, we have a lot of information about transfusions. And so we actually have hand collected a lot of data about mean hemoglobin throughout a patient's ECMO run. We actually have hand pulled out all of the hemoglobin levels that immediately preceded a transfusion order from the
That's fascinating.
EHR. Yeah, and this is a lot of like painstaking work that was done, some by me, but some by my co-authors. This is sort of the culmination of years and years of work.
That's pretty impressive. Data. That's very impressive.
This is like, it's like a lineage in the Duke. So I started this work when I was a fellow, and this is, something that has carried on through now that I'm a medical instructor at Duke. Yeah. And actually one of my co-fellows helped finish the project. So we have this data, but I think we recognized that there's an inherent flaw in a design of a study where you just chop people up into cohorts and then look at differences between, whatever outcomes you choose. And the inherent flaw, especially for this, is that our cohorts are defined by time periods, right? And so it's really hard to control for, what we call secular trends or changes in general management over time. So when you're trying to look at the impact of something like institution or protocol, you can imagine that if you just chop up a before and after and look at means and medians, that you can have a difference, but that might not actually be related to your intervention. And so we decided that we were going to try and do segmented regression analysis, which is a form of interrupted time series, to try and see if there was actually a temporal association between the implementation of our protocols and changes in transfusion practices. So that's really what we were trying to look at, right? Is, there's other publications out there that say, hey, look, before we changed our threshold, our mean hemoglobin was 9, and after we changed our threshold, it was 7, and all of our patients did better, right? But it's really hard to assign any sort of causality. And even in our paper, we can't assign causality. But if you imagine that there's like, a straight line that is just going down over time, if you chop that line in half, the median will be and mean will be higher on one side and lower on the other side.
Yeah.
But that doesn't mean that the intervention that happened in the middle was actually the cause of that change. And so that's why we wanted to look at this in sort of an interrupted time series fashion to see if, hey, we implemented this protocol. Did it actually have the effect that we think it had?
That's amazing. I'm still super impressed with your database. I just want
I really.
That's amazing.
I really want to highlight that this is this is entirely due to the foresight of Craig Rackley, who, when he took over as the medical director of the ECMO program, I think like in 2015 or 2016, realized sort of how unique it was that we were managing our patients in a medical ICU, and started this database like a long, long time ago, and started collecting this a long, long time ago.
Yeah.
Which has really actually facilitated a ton of research for myself and other people here at Duke.
Yeah, huge foresight on his part. That's awesome.
Yeah.
Awesome. Yeah. And can you share then with our listeners how you guys choose your selected outcomes? You touched a little bit on them, but I was hoping you could go a little deeper into why the particular outcome for number of red blood cells transfused and then volume for secondary outcome?
Yeah. So that's a really good question, right? Because you look at a study like this and you think about these incredibly sick, critically ill patients, and you say, well, why aren't you looking at sort of like a more patient-centered outcome like survival or, organ support-free days? And the reason we did this is because one, because of the nature of the data, right? So it's retrospective, so it's really hard to make these associations between, red blood cell transfusions and survival when there are so many uncontrolled variables.
Yeah. But to me, I'm sorry to interrupt you, but to me, what you chose is super patient-centered because again, we all know too much volume is directly associated with poor outcomes in critically ill and things like that. So super patient-centered. I am just curious about why you chose particularly this primary and secondary.
Yeah, so what we really wanted to look at was to try and find as direct what you could argue would be a causal link between our intervention and an outcome.
Okay.
Right? And so what we wanted to do was say, if we change our threshold, does that change how many red blood cell units we give to a patient? And in general critical illness, there is this, knowledge that more volume is bad, but specifically within the ECMO sphere, there is at least a fair amount of retrospective data that associates an increased number of red blood cell transfusions with poorer outcomes, right? And so we just felt like the proposed causal link between, our intervention and the outcome of red blood cells transfused per day of ECMO was going to be the most direct, the direct association that we can make without sort of like other intermediate steps, right? We looked at volume as sort of a secondary outcome because we thought it would have an effect. But it wasn't, there's many other things that can affect the volume that a patient receives over the first, 5 days of their ECMO course. But we really wanted to sort of like hone down as close we could to really look at, again, we can't assign causality because it's retrospective and because of the methodology, but we thought that the hypothesis of a direct link between those two things was the strongest. And so that's why we looked at it as our primary outcome, with the acknowledgement that within this special population of ECMO patients, that we think transfusing less blood is probably better if you can do it.
Better, yeah. Kind of like what we are seeing more and more with overall critically ill patients, right? Regardless of being on ECMO or being on vents and all of that. That's awesome. So now the good part of a study. Tell us about your results. Tell us about what you found and tell us everything. Yeah.
So I guess I'll tell you what we expected to find and then what we actually found, right?
Love it.
And I think we were a little bit surprised by our results, which is always kind of a fun thing when you do research. So we had hypothesized up front that what we were going to see was that we implemented our protocols. This would lead to a change in our transfusion practices. We would give less blood. And we thought that because of our numbers that we actually wouldn't be able to see a change in outcomes aside from like maybe volume status, right? We looked at other secondary outcomes, including in-hospital mortality, but we didn't really expect to see any of those changes. So what we had hoped to say was, hey, look, we did a study, we implemented these transfusion thresholds, there were changes in our transfusion practices, maybe we gave less blood, maybe we gave less volume, but it really didn't affect patient outcomes. And what we found was kind of totally different from what we had hypothesized, which I think actually makes the story a little bit more interesting.
Absolutely.
And so the first thing that we found was that our implementation of our transfusion protocols really didn't have an effect or a measurable effect on the amount of red blood cells that we gave to patients. And this was more probably because we as a group of practicing physicians had started changing our transfusion practices before we implemented the protocols. So essentially what it looks like happened is that we didn't wait for the new protocol to come out to start giving people less blood. Once there was sort of this, once in sort of the mid 20-teens, data came out that giving more blood to patients on ECMO might be associated with harm. It looked like we changed our practice before the protocol, right? So, from the get-go, we gave less blood in the 3 different cohorts we had. And I guess I should explain this. In our paper, there are 3 cohorts. One is our first cohort when we didn't have a defined institutional transfusion threshold, where people were sort of following ELSO guidelines, which was at the time to transfuse to hemoglobin of 12 to 14. 12, and I think in-house, we kind of aimed for greater than 10. Okay. And then we had the institution of our first protocol in 2016, which is recommending transfusion for a hemoglobin of greater than 8. And then our second protocol in 2018, which is transfusion for a hemoglobin greater than 7. And what we found is that there were differences in the amount of blood that we gave to patients in each of those cohorts, and there was differences in hemoglobin. But if you looked at the mean hemoglobin before transfusion, that there wasn't any meaningful difference between the cohorts because or there wasn't a meaningful difference in segmented regression analysis because we started changing our practice before we would implement protocols, which I think was kind of a surprise for us. I think we had assumed that we would see these nice sort of like stepwise decreases in the amount of red blood cells that we gave and the like mean hemoglobin and the pre-transfusion hemoglobin. But that really wasn't the case. It looked like it was more sort of like we were catching up with implementation of our protocols to what had already happened in the ICU. So I think that surprised us, one. And then what surprised us too was that in our secondary outcomes, especially with mortality, we observed what appeared to be maybe what you would call a U-shaped trend with mortality and transfusion. And what I mean by that is we had expected that there wouldn't really be a difference in the hazard of inpatient mortality between the 3 cohorts. Mm-hmm. And what we found was a little bit different. What we found was that there was appeared to be a lower hazard of death in our sort of our middle cohort, so the time that we're transfusing for a hemoglobin greater than 8, when compared to both the no protocol era when we were transfusing probably more to get like to 9 or 10, but also to the second protocol era when we were transfusing for greater than 7. And that kind of surprised us, right? Because we thought that there was like not going to be much of a change associated with this at all. And maybe mortality gets better over time, that you wouldn't see these sort of like distinct changes. Yeah. Again, we can't assign any sort of causality to that, but I think it sort of surprised us because our expectation was that, mortality would continue to get better, over time. And we controlled for baseline illness scores, right? So we thought maybe we're trying to put sicker people on ECMO as we went on, and we couldn't really see that based off of either the REST score or the SOFA score for patients at the time of cannulation. We tried to remove time from the equation by not grouping on cohort identity and just looking at the pre-transfusion hemoglobin, right? So if you just took all patients and looked at the hemoglobin before transfusion and looked at sort of like the mean value, we saw this, what we thought was looked like a U-shaped curve, where once you start transfusing people below 6, that was associated with an increased mortality. And that was kind of surprising for us because we didn't really expect to see that.
It was very surprising to me too. And just for our listeners, if you have the manuscript in front of you, we're talking about figure 4A and B.
Right, figures 4A and B, right? So figure one of those panels is looking at the expected mortality based off of the pre-transfusion hemoglobin, which sort of nadirs around 7.5, and once you go beyond 7, sort of towards the left side of the figure, it starts to increase again. And the other is looking at mortality as it relates to the number of red blood cells you get over time. And
that one was the one that kind of like the shape of that curve, figure A, for A was the one that honestly I was like, whoa, I was not expecting that one.
Yeah, and neither were we. And there's a ton of caveats that we try to acknowledge in the discussion, which is, it's really hard to control out all the variables, right? So people who people with a hemoglobin a hemoglobin in the 6s might just be, sicker. They could be bleeding, and we know that bleeding is associated with an increased risk of mortality on ECMO. But it was a surprising finding for us, and we thought it was one that, we just thought it was surprising and one that would be pretty interesting to most people who looked at it.
Absolutely. And has the practice in your ICU changed based on your findings?
Not yet. And I think this is sort of the recognition of the limitations of this study. And the limitations of this study are that what we just talked about, right? It's hard to control out everything that could be giving us these findings. And we still recognize that blood is a scarce resource, right? So we don't want to be transfusing people if we don't have to. And there are still sort of limitations to this research that we can't control away. And
Absolutely.
the other thing that I will acknowledge is that there's a prospective study called PROTECMO that was published in the Lancet Respiratory Medicine, I want to say in 2023, which is sort of a larger prospective study. And their findings are a little bit different than ours. They do support the idea that once your hemoglobin gets into the 6s, that's when mortality really starts to increase, but they didn't see a benefit to transfusion until you transfuse below 7. So while we have our in-house data and it might be more applicable to us, there is some, I would say, conflicting evidence out there. Again, nothing that's like a solid prospective randomized trial on which to base our practice, but it's still out there, and it's something that we're kind of actively debating as an ECMO program here.
Yeah. But we need data and findings like yours that are surprising or somewhat unexpected to make us think, right? Like make us think, what can we do better? What can we do different? So I'm really, really honored that you said yes to talk to me about your work. And so as a parting gift for our listeners, share with them 2 or 3 take-home points and a little bit of what you would recommend right now based on what you found in terms of clinical practice.
Yeah. So I think there's a couple take-home points. And one is, I'll get on my soapbox here and say that we need better data to guide the management of patients on VV ECMO.
We love a research soapbox, so go for it.
So this is my research soapbox, and we need better data and we need trials. So the use of ECMO has exploded over the past decade for patients with ARDS. And this is obviously accelerated by the COVID-19 pandemic. But we do not have the type of data to guide the management of these patients that we do for other critically ill patients, right? So we don't have prospective randomized trials looking at just basic stuff, right? How much blood do you give? What's your transfusion threshold? What is your anticoagulation target? Should we be systemically anticoagulating people? How do you run the ventilator? These are just sort of like fundamental questions that actually do vary pretty significantly between centers, and I think can have humongous outcomes or effects on outcomes for patients on ECMO. And so what we are really focused on as a research group here is trying to make that next step and moving towards prospective trials. So we have been part of sort of small pilot trials and some in-house pilot trials that are prospective, looking at these sort of fundamental questions. And I would say if anyone out there is interested in researching these fundamental questions in a prospective fashion, please reach out to me, because I think there's a growing community of us, and the more collaborators we can get, the better, because this is a hard thing to study, and to get the numbers that we need, it's going to take a lot of people. But so that's my research soapbox.
Love it.
I think the other clinical take-home point that I got from this is that I think if you follow the ELSO guidelines right now, which are to transfuse between a hemoglobin of 7 to 9, right? So you target between 7 to 9, is that you are likely safe and not going to harm your patients, right? And so I think if that's your goal, I think our data supports those guidelines.
Yeah.
Now, whether or not, 7 is better than 8 is better than 9, I don't think you can look at our data and say, hey, if you move from 8 to 7, that's gonna change outcomes. There's just no way I can sort of like recommend people do that. But I can say that if you look at the ELSO guidelines that recommend a hemoglobin level between 7 and 9, I think that is right now the best thing to do. And in the absence of better prospective data looking at actual individual transfusion thresholds.
Love it. I think those are great take-home points. And Dr. Pratt, how do people find you if they want to join your team for research or just bounce ideas off of you? Yeah.
So the easiest way to talk to me is to just email me. My email is elias.pratt, elias.pratt, Pratt, @duke.edu. And I'm like just an ECMO and vent nerd. So if you ever want to talk about ECMO or vents or research into ECMO or vents, please reach out, because that's like pretty much what I spend most of my life thinking.
Yeah. And are you on social media at all, so people can find you?
I am on social media. I'm probably not the most interactive person on social media. That's okay. I do have a Twitter handle. Let me see if I can remember what it is. It's at Elias_Pratt is my Twitter handle.
Love it.
And that is just me talking about ventilators and ECMO and clinical trials methodology and the critically ill, which are sort of the three things I'm really, really interested in.
Absolutely love it. Dear listener, I had the absolute pleasure of talking to Dr. Elias Pratt from Duke today. We talked about his amazing work on association of RBC transfusion thresholds and outcomes in medical patients with acute respiratory failure supported with extracorporeal membrane oxygenation. Dr. Pratt, I cannot thank you enough for joining me today, and I hope this is the first of many.
Yeah, thank you guys so much for having me. This has been awesome, and I'm just glad that people are excited about our work.
We are. Thank you so much. And again, I'm Alice Gallo, intensivist at Mayo Clinic in Rochester, Minnesota. And on behalf of Chest Journal, thank you so much for listening to this podcast. Have a fabulous day.